Uh, Thank you so much, Deanna, and welcome everybody. Excited to be the first person or guinea pig for the lightning round presentations. It's a wonderful introduction to what I'd like to talk about today is thinking about intimate partner violence and reproductive health, and really thinking about going beyond the associations that this center and many others have documented over the past couple of decades to exactly what's happening there and how might we present it. Deanna has already really covered this material in terms of the very high prevalence of intimate partner violence, the great risk that we've seen intimate partner violence poses in terms of adolescent childbirth, unintended pregnancy, also abortion and multiple abortions, certainly not surprising in terms of thinking about reproductive autonomy. In terms of family planning, men who are abusive are more likely to refuse to use condoms. They're more likely to be coercing their partners against their will to become pregnant, to coerce their partners who do become pregnant to have an abortion against their will, or to actually continue a pregnancy against their will. So broad spectrum of reproductive control. The central question I want to address today in this presentation is whether IPV is directly responsible for poor reproductive health, because certainly we see these associations, they're robust and they're consistent, or is it a marker for other behaviors that may more directly impact contraception and pregnancy. So with my colleague Elizabeth Miller, who's now at the University of Pittsburgh, over the past decade or so, we have conducted a body of research that's identified the phenomenon people may have heard of called reproductive coercion. And these are behaviors that directly interfere with contraception and pregnancy, reducing female reproductive autonomy. It relates to intimate partner violence, but it is in fact distinct. Pregnancy coercion is coercion to gain compliance with the male partner's desire for a female partner to become pregnant, or that his desire that she continue or terminate a pregnancy against her will. The other form of reproductive coercion we talk about is contraceptive sabotage, which is purposeful interference with a woman's attempt to contracept. Intimate partner violence, not surprisingly, increases the risk for reproductive coercion. But it's important to note that reproductive coercion is actually independently associated with unintended pregnancy, so beyond the effects of IPV, and it interacts with IPV to increase the risk for unintended pregnancy. So this is a phenomenon that is actually quite a bit more prevalent and appears to be far more proximal in terms of its relationship to these poor reproductive health outcomes. Oh, went the wrong way. This is a concept that actually has been demonstrated to be relevant in other global contexts. And what we've came clearly to the conclusion that we need to figure out how to address not just IPV, which many people talk about, but also reproductive coercion in the context of family planning, where this is intimate partner violence. Screening identification has been conducted in many parts of the world, but there has been no program that's demonstrated a reduction in reproductive health risk related to this. A program that we've developed that we're very excited about called ARCHES, which is addressing reproductive coercion in health settings. This is a very brief program conducted within routine family planning practice, using existing family planning personnel, making it both a sustainable and scalable program. We have many, there's three basic components. I can talk about this people later. We've had two RCTs that have been in the US at this point that have demonstrated its impact on reproductive coercion and actually on intimate partner violence, and we'll soon be assessing via our recent and ongoing RCT the effects on unintended pregnancy. This work has resulted in important policy change here in the US with new clinical guidelines issued by ACOG, the American College of Obstetrics and Gynecologists. So we've had a huge impact here. Next steps, we are very much focused right now on adaptation of ARCHES for low and middle income countries. We're actually, my team and I are off in 2 days to Mexico City. The Mexican government very much wants to adapt and implement this program for many of our Mexican colleagues. obviously, in that context, we're looking to rigorously evaluate that and figure out how these things, how arches might be scaled in these contexts. We're starting in Mexico. We have a great deal of interest, though, where there are other opportunities. We're looking at that certainly in South Asia now to pilot the program. Just acknowledge my collaborators and end notes, and thank you very, very much.